Okay, we are back and we're going to talk about peripheral neuropathy. Um, I'm utilizing Miss Graham's PowerPoint, but I am doing the voiceover. So go ahead and follow along with the student version that you have. Learning objectives are the same, so sensory impairment or perception. So we want to make sure that we're applying the nursing process and teaching strategies as well as nursing interventions. So talking first about introduction and etiology or patho of peripheral neuropathy. So you may have heard of diabetic neuropathy, and that's a little different than peripheral neuropathy, right? So it's damage to the peripheral nerves, which would be your arms, your legs, your hands, and your feet. So all of those places. And it's divided into your sensory, motor, and autonomic nerves. So your sensory nerves receive information, motor nerves transmit signals, and your autonomic nerves assist with involuntary functions. As you can see here, you have a healthy nerve cell and an unhealthy nerve cell. So there's damage to that myelin sheath, what's called, which covers the nerve cells, which causes a loss of feeling for the patient. So that can come from either causes from hereditary or genetics, or types of diseases like diabetes or kidney diseases, inflammatory diseases, or autoimmune, such as Guillain-Barré syndrome, Lyme disease, or HIV. Certain types of trauma can cause this loss of myelin sheath or damage to the nerve cells, like carpal tunnel, or nerve injuries like nerve compression, or nutritional deficiencies like vitamin B deficiency. Certain toxins like substances, alcohol, toxic chemicals, toxins like chemotherapy. So if the patient is on chemo, it can cause chemo-induced peripheral neuropathy if it's dose related. And so we want to make sure that we're assessing the patient as to why they might have this certain disease process and figure out an intervention that's targeted towards that. So again, peripheral neuropathy has to do with all peripheral extremities, not just limited to lower extremities. It has to do with all arms, feet, legs, and hands. Okay. Prevention strategies, right? We want to aim at preventing the patient from getting this in the first place. If it's genetic, it is a little more difficult to prevent that, right? But if we control an underlying condition like diabetes, we can prevent them from getting peripheral neuropathy. So aggressive management of diabetes and blood glucose control. Kidney diseases, we want to make sure they have that under control. They take their medications. Lifestyle changes, we want them to have a healthy diet. If there's a vitamin deficiency, we want them to have more fruits, vegetables, whole grains, appropriate vitamin intake. They might have to supplement with multivitamins, and then avoid any substances or alcohol. And then exercise properly, so at least 30 minutes a day, or participate in physical therapy if they're more at risk for developing peripheral neuropathy. And then avoiding triggers, so repetitive motions like being on the computer, or being at risk for getting carpal tunnel syndrome, or prolonged positions that put pressure on those nerves can cause that. So we want to definitely emphasize those prevention strategies. Complications that can arise from peripheral neuropathy. So the patient may lose sensation, right, to those peripheral extremities because of the nerve damage. So they won't be able to recognize that they have a cut or a blister or a burn, which leads to skin breakdown, so which leads to infection. And that can cause an amputation in the long run. So we want to prevent that from happening and recognizing when it happens. This happens with your diabetic patients, right? So they don't know that they have a blister or ulcer because they can't feel it. So they need to do daily inspections, and we'll talk about that later. They're more at risk for falls because of the lack of feeling and mobility. Impaired balance and gait, and then dizziness can cause that also. Chronic pain, patients with this condition or alteration, it can cause pain because of the numbness and tingling and then the nerve damage. Okay, it is debilitating, and it can cause a significant decrease in the quality of life. So we need to make sure that pain is under control. And there's a medication that we're going to go over that can help with that nerve pain. Patients can feel anxiety and depression because they can't do the things that they've liked to do in the past because it's very painful. So we want to increase that quality of life. Muscle atrophy and deformity, so wasting of the muscles in the feet and the hands because they're not using them as much and it hurts. And then it can cause what's called Charcot-Marie tooth disease. It has nothing to do with the teeth. It's a hereditary disease that can cause that. And then a loss of ability to perform activities of daily living. So they're not able to get themselves dressed, brush their teeth, brush their hair, put on their shoes because it hurts so badly. So we want to be able to get that under control so they're able to do those ADLs effectively. So what are our cues of peripheral neuropathy? That has to do with these, okay? So numbness and loss of sensation in any of the peripheral extremities, so feet or hands. So it might feel like that foot or hand is falling asleep, and that's a common clinical manifestation that the patient might report, right? It feels like my hand or foot is falling asleep all the time. It could feel like it's burning, like maybe they're stepping on hot coals, okay? They feel that tingling feeling or shooting pain up their legs and cramping. They're having issues with balance or mobility and gait because of that nerve damage, and that myelin sheath is causing muscle breakdown, so they're not able to walk effectively. They're also very sensitive to hot and cold, so they're not able to regulate temperature as well. And we'll talk about that a little later on too, about education on temperature regulation. So what are we going to ask the patient, right? What have they been feeling lately? How long has this been going on? What does it feel like to them? And where? How often does it feel this way? How often do they feel numb? How often are they feeling this from day to day, right? Paresthesias is the medical term for it, the pins and needles, right? They feel like they have pins and needles in their hands or their feet. So that can be painful. It is a safety risk because if they have impaired balance, they are at risk for falling, okay? And they're at risk for dropping things or impaired mobility, as I said, and also reporting dizziness. Some less common ones that are reported would be erectile dysfunction or constipation because of the autonomic nerves that are impaired. But they're going to have difficulties with fine motor tasks. So if they're having nerve damage in their hands, they're not going to be able to tie their shoes as well. So asking about their ADLs and how that's been affecting them from day to day is going to be an important question to ask. Okay, so think of subjective and objective findings. What is the patient going to say to you? And what are you going to find on them? Because you might not really see the numbness and tingling, so you need to ask the patient, how does it feel? Tell me more about how this feels and where it's located. Tell me more about how the temperature feels when you turn on the faucet. Does it feel hot or does it feel cold? Also looking at their feet, what's common is called foot drop because they're not using their feet as well. And so their foot may be dropping, okay? So we've recognized the cues, and then we also need to analyze them, right? we need to correct or manage the underlying cause, and we need to figure out what might be causing it. So we need to draw some labs, which would be our CBC, metabolic panel, CMP, vitamin B12, if that's the deficiency that may be causing it, and then what's called an electromyograph or EMG, which would be a needle inserted into the muscle, and then a neurologist is going to tell you to contract the muscle, and then it'll record the activity during movement. So we want to see how well that muscle is functioning and the extremities that the patient is reporting numbness or tingling. Okay, and they might do a nerve biopsy to see if there's something affecting that muscle. So we want to correct the underlying problem and assess the safety risks. Okay, so our key factors are risk for injury, right, for this patient. So we want to make sure we address that. Okay. So asking the patient also any history and physical, any family history of neuropathy. What is their medical history? Have they had any surgeries for this before? What is their lifestyle? What is their current diet? How are they using the restroom? Because less common, like I said, is constipation, but we still want to ask. What are they reporting? What is their psychosocial assessment? So asking them about their impact of quality of life and their ADLs, and then assessing those labs to see if there's an underlying cause. If it's diabetic related, then we would take their blood sugar and their A1C, and then see what that EMG or electromyograph reports. Okay. Next, we're going to go on to the nursing process. So our priority problem for this patient would be risk for injury or falls, right? Because they have impaired coordination and they're having nerve damage. Chronic pain would be another one. Deficient knowledge and ineffective coping. So maybe they're not knowledgeable enough in their disease process and how to take care of themselves with this disorder. So we need to make sure that they have enough knowledge. And then also with assessing their comfort or coping and how are they able to function day to day. Who can we collaborate with? So we have our PT and OT, physical therapy and occupational therapy, if the patient's having a problem getting dressed in the morning. Occupational therapy might be able to help them, and then physical therapy is going to help them with their mobility and make sure that they have the accommodations that they need to get around and move correctly, whether they need a walker or a cane, and then or any type of assistive device, especially for those patients who might experience the foot drop because they're not using their feet enough. We might also collaborate with neurology, right? Because they're the providers that actually will make recommendations for interventions for this patient. They're the nerve specialists. Pharmacology will definitely be collaborating with. Your medication gabapentin is one that you're going to be focusing on for this module, and then pain medications for this patient. That drug therapy is individualized to manage pain, so it really depends on how mild, moderate, or severe the pain is. And then they might be prescribed anticonvulsants because that also works on the nerve part of the brain, and then maybe even some antidepressants or a lidocaine patch for pain. And then just a couple tidbits on gabapentin that I do want to discuss. So if you want to take some notes here, for gabapentin, never stop taking it abruptly because there is a risk of withdrawal or seizures. Take around the clock, okay? It's not a PRN medication. It is a scheduled medication. They should not stop taking it just because they're feeling better. They need a consistent level in order for the medication to work effectively. They need to report any dizziness, drowsiness, and avoid driving until the effects are known. And then they shouldn't combine with any other CNS depressants, like benzodiazepines or opioids. Okay, so make sure the patient knows that they should be taking it around the clock as scheduled. Okay. Some solutions to the problem. So we just talked about pharmacology. They could have surgery. They might have, if they're having compression to the nerve and it's really causing them poor quality of life, they might have some surgery to help out with that. If they're having peripheral nerve injuries, they might have foot reconstruction, especially in that inherited disorder. Like I said earlier, the Charcot-Marie tooth disease, it's an inherited disorder that it can affect the peripheral nerves. So we might need to stabilize the ankles, straighten out the toes, and flatten the high arches to make sure the patient has a high quality of life. Some other solutions might be some complementary ones, which would be non-pharmacological. Apply heat or cold, but we do have to be careful because that patient can't feel as well. So we have to help regulate the temperature and teach the patient how often they need to apply heat or cold, right? 30 minutes on or off. So they need to set a timer to make sure they're not keeping that heat on for too long. The TENS machine has to do with applying the electrodes actually to the nerves, and it's not invasive. It's usually, you can buy this off online. It's not invasive, and it helps apply electricity to the nerves to help relieve pain. And then providing that emotional support for the patient. Home safety education, and we'll touch on this more in the next slide. And then providing comfort for pain and analgesics, and then validating feelings and concerns related to sensory loss, and then assessing patients' mood and anxiety and sleep patterns, making sure that they're participating in ADLs. So our priority need would be what? Safety. They are a fall risk. That is our priority need for a patient who has peripheral neuropathy. Again, our priority need for a patient who has peripheral neuropathy is safety, safety prevention. So what can we educate about? We are going to educate about foot care, okay? Some foot care tips for healthy feet. We want to make sure that they do daily foot inspections. They take a look in between their toes. They wear well-fitting feet. Well-fitting protective sole shoes. Don't soak their feet, but wash them and rinse them daily. The reason they shouldn't soak their feet is because it can cause skin breakdown if they soak them for too long. And actually, patients that can't feel, they're not going to be able to feel that they're having that skin breakdown down there. So they want to look for nail problems and blisters. Pat dry in between the toes. Apply the lotion as needed to tops and the bottoms, and avoid any flip-flops or sandals so they don't have any blisters or any wounds that may open up on their feet. Make sure they're getting any nail trimmings done by the provider, especially if they have hardened nails or they're cutting straight across and then they're going to file down. Never go barefoot. They wear shoes that fit well. Wiggle the toes to increase blood flow, and then they check their feet every single day. For the temperature regulation, we want to make sure that these patients, both if they're having peripheral neuropathy in their hands, they need to test the water with a thermometer, not just their hands because they can't feel it, right? So they should keep a thermometer nearby, and then use some gloves for doing the dishes and also gardening, right? Because they don't want to have skin breakdown or open wounds, and then it'll cause an infection in their hands. So teach the patient to get some gloves for doing the dishes in the kitchen, and then use some gloves outside to prevent any risk of infection. Mobility, the patient should stand in place before walking and then getting out of bed to make sure they don't have any dizziness. And then using any side handrails when they're walking up the stairs or down the stairs, and utilizing their assistive devices if they need it, especially if they have issues with coordination or balance. They're going to need to use a cane or a walker every single time. Stress the importance of reporting any new medication side effects, especially with the gabapentin, if they're having worsening dizziness, if they're having any new fever or rash or blisters or ulcers to the feet, hands, that doesn't heal, they need to report that to the provider. Any new numbness or tingling, so maybe they just have it in their hands, but now they have it in their feet, or they just have it in their hands and now they have it in their arms, they need to notify the provider. That means it's progressing. Box 1812 has patient teaching. It does say chemo-induced, but this is applicable for all types of peripheral neuropathy. So please take a look at that box to make sure you know about patient teaching. Let's evaluate outcomes. So what is our priority need? We want the patient to have safety prevention. So we want them to call, not fall. We want them to be able to reduce risks of falls in the home. So make sure they have safety initiatives in the home, clutter out of the way. They're having any handrails or benches in the shower that they need. They're getting the rugs out of the way. They're not tripping over things. They're using their assistive devices. Maybe they need a call alert button or a necklace. And then we want pain to be under control for that patient. We may not be able to get it to a 0 because that may not be realistic. But what is the patient's pain goal? What are they able to tolerate? This is going to help them rest and be comfortable with the outcome of their disease process. They're able to list some strategies to reduce injury, and they're able to tell us and do the teach back of how they're going to prevent any injuries or complications. They're able to participate in physical therapy. They're able to be compliant with medications. They can describe their treatment plan, and then their pain is under control. Okay. Of note, right, and it says here on your slide, neuropathic pain is chronic, so there's no real cure for it, but we want to be able to get the patient to have a high quality of life and be able to get that pain under control. But any worsening symptoms, like I said, if their pain is moving from their hands to their arms or their feet to their legs or any of their extremities, we want them to address that as soon as possible because that means it's not getting any better. So what are some challenges with your lifespan consideration, right? Because we don't want to assume that everyone's the same when dealing with peripheral neuropathy. With pediatric clients, it is very difficult to assess pediatric clients and understanding where their pain is coming from in the first place. So we need to make sure that we're using different pain measurement methods like the Baker-Wong scale, and then asking some questions that are related to their age, right? So they may struggle to describe this paresthesia. So some questions you can ask pediatric patients might be, do your toes feel like they have ants crawling on them? So that could be more for your smaller patient, the smaller children. Or do you have hands or feet? Do your hands or feet ever feel tingly like when they fall asleep, right? Do they feel like they're kind of like tingling, or do they feel like little stuff is crawling all over them? Or do you feel like you can't move it sometimes? So making sure that you're catering to what their understanding level is. CPIN or chemo-induced peripheral neuropathy. So these children who are receiving chemotherapy are at higher risk for developing peripheral neuropathy. They can have more aggressive behavior because of the pain, anxiety, aggression, because they're deflecting, they don't know how to express the pain. So making sure you're assessing it in the way that they can understand. It could also be hereditary. Again, with the Shakara-Marie tooth disease, they can develop it because of a genetic disposition. Pregnancy and breastfeeding, we need to make sure that we address medication use. Gabapentin can pose a risk to the developing fetus, so we need to make sure we weigh the risks versus the benefits during pregnancy and lactation. your geriatric population is probably the most defined population who may develop peripheral neuropathy. It increases with age, and especially all the comorbidities that these patients may have. Higher risk for falls, right? Impaired mobility and coordination because of that lack of sensory perception. So we want to make sure that we are assessing that and asking this patient every time we do an assessment. Do you have any numbness or tingling anywhere? Do you have any history of diabetes? Do you have any issues with balance or walking? Do you have any issues with vision changes or dizziness when you stand up? So asking that patient will help guide your interventions. With medication use like gabapentin, we want to start low and start slow and go low, right? Lower starting doses, we make sure so potential for confusion and drowsiness. And as we get older, we have decreased kidney function. So we want to make sure that that gabapentin has time to process. Check on learning. One question before we leave. A client with peripheral neuropathy is prescribed gabapentin. What statement by the client indicates a need for further teaching? Further teaching, okay? Need for further teaching. That means what is the wrong statement here, okay? I will take this medication at bedtime to reduce dizziness. I can stop taking this medication once my pain goes away. I may feel sleepy when I first start taking this medication. I will avoid alcohol while taking this medication. See if I can highlight here. All right. The right answer is B. Okay. They should not stop taking the medication just because the pain's going away, right? Take as scheduled. It's not an as needed medication, okay, around the clock. All right, so remember that about gabapentin. Everything else is correct, right? This is correct? Sure. Take it at bedtime because if you need to lie down, that probably is a better idea. Yes, you may feel a little bit sleepy or drowsy. Correct. You should not take alcohol when taking the medication, right? Because it's going to exacerbate the effect. So this is the correct one. All right. I hope that was helpful for you. Let me know if you have any questions. Thank you.